next edition of the weekly webinar. And tonight our title is all about changes to the outpatients clinic in our COVID-19 era. And this is all, I suppose, part of a theme of actually how do we get our services back up and running. I know many people are actively doing that as we speak. The HSE are putting out various guidelines to people on getting services back up and running. These are kind of high levels, so clearly at a local hospital level, people are going to have to figure things out based on the resources, the space, the construct and everything else that they have to try and deal with, and yet maintain the various constraints that the COVID-19 infection is bringing to our services. But I think the narrative is moving on from how to deal with COVID-19 patients and deal with the potential surge. We're now moving to a place where it's all about how do we deal with the unmet need, the massive waiting lists that possibly have built up over the last couple of months. And this is going to take a truly integrated approach across all sectors of the health services. And so tonight, I'm delighted to say we have a very broad representation of everybody in the services tonight. As always, we'll start off with the President giving us an update on things and the various interactions with the department and the HSE and so on. Then that'll be followed by Professor Colm Bergin, who is a consultant physician in infectious diseases, and we'll talk about the changes that we need to really consider if we're going to start opening up our outpatients and get patients moving through the system again. Then Ger O'Boyle, who's an advanced nurse practitioner in Galway in the area of prostate radiotherapy, will certainly give us a very good, insightful overview there. Then we're going to talk about the virtually perfect, which is a great which is a question mark, by the way, telemedicine and what that means. That's Mr. Tony Moloney, who's a vascular surgeon in Limerick, and we get a good insight there. And all of these challenges in running outpatients, virtual clinics, different ways of managing things is going to lead to lots of challenges in how we do communications, communicating with each other, communicating with patients, communicating with family, and across the various sectors of the system. And so Professor Peter Gillen, who's well known to everybody, and he's Associate Professor of Surgery in RCSI, and he's an advisor to the National Healthcare Communications Programme and has done some very, very important work in this area in the last couple of months. And then finally, we're going to hear from Dr. Tony Cox, who's the Medical Director of the Irish College of General Practitioners and is a GP in Ennis, and will give us a very good understanding of what the GPs, which is the first point of contact for all our population who will want to get access to services, and certainly hearing what the requirements for general practice are going to be will be vital as we consider all these areas. So as always, I ask you to mute your microphones, that's everybody, and then as the speakers come on, just to unmute. As always, Erica will deal with the slides, and you just shout next slide and we move on to the next slide. If you're not using slides, of course, that's no problem at all. And then if you use the chat function on the MS Teams to send in your questions, your queries, your comments, we'll put them to the panel afterwards, or we'll deal with them during the talks. And during the talks as well, you'll see various links going up from the team background in relation to kind of the updates from college. And maybe it's worthwhile just maybe summarising some of the things that have been going on. As you know, we've had the GP Surgeon Connect initiative going for a while, which has been helping to get advice, quick, accessible advice where needed by GPs for their patients from a surgical consult, and help move things along there. And there's been a lot of visits to the website. We've over 50 fellows involved in delivery of that service, and I think it's been going pretty well. We have had we've nearly about different various initiatives run by the National Clinical Programmes, which you've heard over the last few weeks in trauma and orthopaedics and in surgery and emergency medicine. And they've been dealing with a range of different initiatives over the last couple of weeks, which we keep people up to date on, and they're all published on the college website under the surgical practice section. And there's over 17 new national guidelines there published, and 15 different guidelines from the various specialty bodies as well, to try and give you as many resources and information as much as possible. So let's just give you an overview of those things that are there. So without any further delay, I'm going to kick off by asking our President, Mr. Ken Mealy, to give us an update on what's been happening in the last week or so.
Kieran, thank you very much, and I'd like to add my voice to yours for thanking our speakers tonight for giving up their time. I'd also like to thank all of you for joining us. As Kieran has indicated, we've introduced a whole series of events to try and support members and fellows around the country. This is our 8th webinar, and I think at this stage we've had over 1,100 people log on to the webinars. We've also had 8 presidential addresses in which we try and summarize all the work that Kieran alluded to. Initially, we concentrated on issues of your safety and patient safety, but now we're getting into the granularity of how do we restore normal activities. And if I can use that word loosely, because I think that we all accept that the new normal is going to be different. In the last number of weeks, we've had our clinical programs, as Kieran has said, outlining strategies for getting back to the new normal. And we've also had our nurse manager colleagues and administrative colleagues indicating how care pathways might work in hospitals. And tonight, as you've gathered, we're looking at outpatient services. Always, we place a huge emphasis on everybody's safety, patient safety, but also your safety. And in that regard, I'd like to just comment on another aspect of RCSI, University of Medicine Health Sciences, because I see Arnie Hill is on the meeting list there tonight. And this afternoon, we had our virtual conference for over 300 new doctors. And I just send a plea out to all of you to support these young doctors when they enter the workforce in 2 weeks' time. Our current interns were 9 months into their internship when the COVID pandemic hit. These new interns are clearly new on the job. They will have a shorter induction period than previous years. And I think it's vitally important that we would support them. Kieran has also mentioned our GP Surgeon Connect. This is an important support for not only surgeons, but also our GP colleagues so that we can communicate better together. And I'd also like to give a plug for our telephone communication skills training. And Peter might talk about that later on because he's been intimately involved with this with Sean Tierney and Eva Doherty. And you can access these this through our website or the M-Surgery platform. So we, as always, want your feedback. We want to hear from you. If you have issues that need to be addressed, if there are particular problems that you think we can help with or share best practice, I would ask you to contact either myself through the President's office or through Kieran through Surgical Affairs. It is important that we all share best practice with each other. The coming months are going to be a real challenge, and we're only going to get through this if all of us work together in different ways. I think we need to be flexible, we need to be creative, and some of the things you're going to hear tonight will be along those lines, how we work differently than we have previously, but try and get back to some sort of normality so that we can provide the care that all of us are trained to do so. So back to you, Kieran. Thank you again for tuning in, and I look forward to the conversation tonight.
Great, thanks very much. So our first speaker tonight then is Professor Colm Bergin, who's a consultant physician in infectious diseases, and Colm's going to talk about the sort of changes we need to think about and consider and implement for running outpatients. So Colm, I'll hand over to you, and thanks again for your time tonight in addressing us.
Right, thank you very much, Kieran, and thanks, Ken, and good evening. I actually don't see my slides, but my name is Colm Bergin. I work in St. James's Hospital, and I've been asked this evening to talk to some work that's going on around providing ordinary care in extraordinary times. Next slide, please, Erica. So I took this to follow on from previous webinars that Debbie and Paddy had spoken to. Next slide. Just in your webinar series addressing the return to normal, and then more recently work that Paddy spoke to around outpatient care services. And next slide. I have a disclaimer from the outset. I don't have any solutions, and I think echoing Ken's comments, I think that this is really about a dialogue about how we are going to integrate a historical business as usual into extraordinary times. So in preparing the next few slides, I've broken it up into 4 phases. In any significant transformation program, to pause and gain awareness, to look then at new knowledge, to stop and reflect, and then how we plan to start anew. And the last few slides are just referencing plans from the HSE pertaining to outpatient care provision. So next slide. You're very, very well aware of the international epidemiology, but I've just identified on this slide the pictorial to the left, which is the first day that the RCPI held a webinar on the 18th of March, and at that time 185,000 infections, 7,000 deaths, and then as of this morning on the Hopkins website, almost 4.3 million infections and close to 300,000 deaths. So just the significant changes that have occurred within a relatively short time period. The next slide, Erica, please, is just with regards to local data that, again, most of you will be aware of. This is just to the right, the confirmed cases reported to the HPSC as of midnight on May the 10th. And to the left, I've made reference, really in the red box, to the number of healthcare workers that are presently accounting for almost a third of all infections within the system. And there's a significant geographical variation to that, which may influence how different systems return to business as usual. Next slide, please. So I've just put this up. This is our experience in St. James's. I know there are some hospitals that have experienced similar effects on healthcare workers. We have a staff of almost 4,300 people, and 10% of those have become infected at some point in the last 8 weeks. We have over 400 cases confirmed positive, and obviously a significant impact on the workforce planning pertaining to both cases leaving work, but also obviously the context of those cases also being removed. Notably, out of the staff of about 4,300, almost 3,500 of them have had an interface with occupational health at some point in the last 8 weeks. Next slide, please. Thank you. So some of you will be aware that this is the proposal from the government for the reopening of services at community health, education and childcare, economic, retail services, cultural and social and transport levels over the coming months. And I think what's important is that whilst this is all progressing within the healthcare system, there will be a need for us not to return to normal. So no trolley waits. No 60 people attending an outpatient clinic, and no 100% or 105% bed capacity within the acute sector. And we're going to have to find a mechanism to which how we're going to deliver all of those issues, particularly if the R0, this number of transmissions that occur with every case, were to increase with any loosening of restrictions in the coming weeks. It is thought that if the R0 lifts to 1.2, it's presently roughly between 0.5 and 0.8, that will lead to a further surge of ICU capacity concerns by the end of June. Next slide, please. So some of the challenges I think that we're all facing, and I'm sure other speakers are going to speak to this, is the access to diagnostics and to hospital care, the inability to run a COVID and non-COVID care pathway at the same time. The non-COVID care pathway is particularly difficult in the context of assuring that neither staff nor patients who may be presenting with traditional care needs do not have COVID. There is a clear need for a national testing strategy, which I'm going to end on. Patients are obviously heavily influenced by events of the last 8 weeks. Prioritization, obviously, around how to address everything at the one time. There is a focus on training and education that I understand is going to be the topic for the Medical Leaders Forum next Saturday. And then other speakers may talk to the interface between primary care, emergency departments, day units, and I would again speak to the disclaimer of this being an iterative process, that anything we do in the coming weeks will need to be offset by any change in the zero and any concerns relating to search activity that will occur at the time. Next slide. So within this context that we're trying to address a new norm. Next slide. Sorry, Erica, next slide. So the only reason I'm putting this in place is that there is an evidence base to some of the things that are being discussed at the moment with regards to the complexity of transformative care planning. So obviously things need to be dynamic. There needs to be resilience within the system, particularly at this time of significant uncertainty, as I've mentioned, with regards to any relaxing of restrictions, to adapt quickly. Obviously, knowledge needs to be shared, and obviously we're going to be talking about the use of technology in a way that we haven't used it before, pertaining to healthcare delivery. Next slide, please. And this is just to identify that there is an evidence based to identifying the infrastructure to high reliable organizations. And again, all these slides will be available for review afterwards. Next slide, please. So I think there are a couple of things that are coming to the fore in discussions for us, and I'm sure that the same in primary care and in your own practices, are infrastructural capacity at base. Most services have limited waiting rooms, most have overcrowded clinics, most have non-scheduled attendances, and most have no electronic patient record systems that allow for scheduled attendances. There is concern, as referenced to PPE access, healthcare worker effect, obviously a significant requirement for behavioural change. There are issues that we haven't quite got to understand around shared accommodation and societal issues, particularly with regards accommodation in large urban areas where a number of healthcare workers, NCHDs or healthcare workers of different disciplines, are sharing accommodation driven primarily by economic reasons of living in accommodation that is prohibitively expensive over the last years. And in those people working in different healthcare settings, is there a concern that some of the issues that we're seeing at hospital level, that we're wondering whether it's healthcare associated, may actually be socially related in the context of where people congregate? And then obviously there's been some work in occupational health around derogation that may have had an influence on healthcare worker positivity. We're at the beginning of a very long journey. I think there is a concern that people think we're coming to the end of something. My personal belief, and I think Ken has spoken to this, is that we're just at the beginning of something else. And then how do we maintain ourselves for the longer term? Next slide, please, Sarah. So this, I think, is the important issue, because this is what people have begun to talk to, and that is the unexpected non-COVID related work increases. So this is data that FIDA has shared, that if you look at the average outpatient attendance in 2019 was just over 250,000. For March, that was down to 200,000. Cancellations were up from 2,500 per month in Q4 2019 to 10,000 in March. The average referrals have dropped from approximately 90,000 per month in 2019 down to 65,000 in March, and notably there's been an increased waiting list in the context of a reduction in the number, and the waiting list increase primarily driven by obviously the reduction in referrals. Next slide, please. All right, thanks. So this is just again a schematic of that data. This is identifying the OPD data across the monthly open time waiting list positions, the number of new return outpatient attendances. You will see the drop from almost 300,000 to 170,000 in March. And then for the first time, the beginnings of recordings of virtual clinics identifying the topic that others will talk to during the evening. Next slide. So having just briefly looked at where we are, then I thought in the second part I might look at new knowledge acquisition. Next slide. So this is a perspective published in the New England Journal recently, for those of you that might have seen it, looking at the impact of telemedicine within the American healthcare system. And a lot of the focus here was around the increasing utility of telemedicine, but more focusing on things like regulatory affairs, consent, and obviously reimbursement in an insurance model, which may be different obviously to here. Next slide. The next few slides, actually, Erica, can go all together. These are just examples of what people have been doing in different locations. So dermatology clinics in Italy, an eye clinic in China. Next slide. Ambulatory dialysis clinic in Italy, and the final slide is an example, I think, of a general approach to outpatient care in China. And they're all saying the same thing. They're all talking about social distancing. They're all talking about hand hygiene. They're all talking, however, before attendance of a pre-triage assessment. And that pre-triage assessment is questionnaire based. That people will be contacted to approximately 48 hours prior to their outpatient visit. They would fulfill a questionnaire around symptomatology, contacts with any known case of COVID in the days prior to their scheduled attendance, whether or not they can be triaged to virtual health review as opposed to attending in real time. Then time of attendance to the hospital, that they would not congregate in a waiting area. There are some centres now looking at removing all waiting areas and reutilising them as rooms. People will be asked to wait. They will be SMS texted to attend at a designated time. They will be referred to a designated room. So they will be pre-triaged to see a certain provider in the outpatient clinic, and not all come and be seen by a random pickup, as we've been running our outpatients for a long time. On attendance to the facility, they again would have a symptom check and a body temperature check, and then hand hygiene, social distancing, and respiratory etiquette. And those are the themes of all the 4 examples that I've taken from the literature that have been reported to date. Next slide. So in the, sorry, next slide, apologies, that's just a cardiology in Germany. In the UK, they have issued guidance from the NHS around remote consultations and working within the secondary care setting in pandemic. There are a number of similar documents issued from the Acute Hospitals Group, from Peter Hamilton's office. I'm not sure they're available yet on the website, but they have been issued out, I understand, to the system, talking to things like governance, clinical accessibility, pre-triage, and guidance for the use of remote telemedicine for virtual clinics. Next slide, please. So virtual clinics are not new. I found this paper from Debbie and her colleagues in Beaumont, where they had undertaken approximately 5 years ago a review of a virtual outpatient review for people post-endoscopy. Almost 160 people reviewed, more than 3/4 completed the questionnaire, and more than 84% of the people that they saw were reviewed and discharged without having to re-attend. So it's that sense of us probably learning from things we've already been doing for a number of years. To the right, I've made reference to a particular virtual health program called ECHO. So that's the extension of community healthcare outcomes. And for those of you that may not be aware of this, this is the program initially started by Sanjeev Arora around the provision of hepatitis C care in large communities in New Mexico. And really, the focus of this is not simply about using virtual clinics for their ease, but using it to demonopolize knowledge and to share knowledge with other providers who will be involved in care provision. Next slide. There are a number of projects that have explored the use of patient portals. And again, this I'm sure will be a topic of discussion during the evening around electronic patient records and a unique identifier for every patient. But there are huge benefits here from the point of view of the individual being able to receive coordinated care, to communicate their different attendances at different places, and obviously to be involved in the management of their care with pre-clinic questionnaires or pre-clinic inquiries. Next slide. So I'm going to finish just a little bit about local experience before coming to a document that has just been prepared. So Colin Doherty has been asked in St. James's to look at how best to return the hospital to outpatient care pathways in the context of a COVID system that has, we have approximately 70 inpatients, 5 people still in ICU, almost 300 healthcare workers still out, and a number of contacts of those cases remaining out of work. And we're trying to find a mechanism of returning to business in the context of where the infrastructure at baseline was not ideal. Next slide. So in taking the first things that were identified as concerns, the biggest issue was understandably space. Next, to managing patient expectations and fear in the context of concerns of attending a hospital where they will have seen reported data relating to COVID activity. The absence of clear protocols for provision of entry and exit for patients, staff development and staff redeployment. A number of chronic disease care units have seen their staff numbers removed as they have left specialty areas to man wards in the context of the workforce planning issues that I've made reference to already. Specifically, a one-stop shop concept around phlebotomy and diagnostics, how better to engage with primary care colleagues in an integrated pathway, and then some concern around the legal issues relating to care provision over a virtual base. The schematic to the top is just an ambulatory care centre in Boston, and obviously these were aspirational goals we've submitted in the time of the Celtic boom almost 15 years ago around basically looking to see ambulatory care centres get developed. Next slide, please. So within phlebotomy, this is just an example of what we're looking at within St. James's. So there are two templates here. One is for remote phlebotomy. So this is where we would look at community-based support structures to facilitate phlebotomy being taken at home. And then for that, those samples to be returned to the laboratory. Access, we're fortunate in the last 15 months to have rolled out EPR within the hospital. So this would allow for those results management to be both endorsed, but also reviewed through the electronic patient record. Next slide. But more importantly, it's how to manage the volume of people coming to outpatients with regards to routine access to phlebotomy. So this is a proposed schematic as to how we think we would use Swift queue to allow people to attend at a scheduled time unless there was an urgent requirement for phlebotomy. Next slide, please. So then, with that in mind, taking what we've learned and where we are at this moment in time in the disease epidemiology, the final part of the talk is just to look at what's being proposed in development. Next slide, Erica. So how do you transform a system and yet keep capacity for concerns relating to end of June research? Next slide. And this is really, again, to reiterate my disclaimer, that this is a draft document. It will be iterative and it will be renewed, influenced by disease epidemiology and by the agility of the system to learn from each step as it moves through it. Essentially, what is being suggested is a QI/QA infrastructural approach to the review itself, and then the pre-outpatient assessment, the peri-outpatient attendance, and then the outpatient visit are really aligned to what has been undertaken in other healthcare systems, acknowledging that obviously our healthcare system is not the same at baseline. There are huge opportunities, however, obviously to support colleagues in role development and a push to try and both look at the way in which we do things and to look at technology as an enabler, particularly with regards combined electronic patient records. Next slide. So this is the expectation similar to what I've described in international experience, that patients will be reviewed prior to their designated attendance to a scheduled outpatient visit. They will arrive at a designated time, and people who arrive before their time will not be allowed to enter. We're looking at reconfiguring some of our space so that people can wait outside of the actual building. This is easy in the summer. It's not something that's going to be easy to do in the Irish winters. And that people will be texted for those that have smartphones and can use them, that people will be called to the suite at a designated time and called to a designated room. So that goes back to the pre-triage evaluation of the cohort coming to see that clinic visit, that they will be assigned to providers prior to their attendance. There is some concern about family members and the number of people visiting an outpatient suite at a certain time, and there may be a need to consider family visits by pre-booking. That's obviously something that can be very difficult, but something that would have to be considered. Seating areas are obviously a significant concern, and we have mentioned some issues here with regards redesignation of waiting areas to clinical space. Final slide. So I'm going to close with what I think will inform the next steps, and that is testing. So this is a hugely topical area that's been the main point of a number of the media lead editorials over the last week and actually for the last number of weeks, and really for us to try and get to a point where we're going to have the capacity to basically test. There is some move towards individual institutions having to introduce something on the basis of the impact of the last 8 weeks on their workforce, but it would be preferable that this would be embedded within a national strategy who to test, what to test for, and how frequent to test. Then I close on my final slide, which is simply, I think, the wisdom of the crowd. I don't think that any one person or any one group have answers. I think it's back to the collective wisdom to try and figure out how best we can introduce some semblance of return to care for those that need access through scheduled outpatient visits. Thank you.
Colm, thanks a million. That's been very comprehensive, and certainly I think most of the things that we've all been trying to think about around space and workflow and prepping patients, notifying them, dealing with all sorts of different issues. You've outlined brilliantly all the things we need to consider tonight. The next speaker is Ger O'Boyle, and Ger, she's an advanced nurse practitioner in prostate radiotherapy in Galway. And we heard last week, if anyone was on the call last week, the roles that our other colleagues across the hospital are going to have to take in this, and the role of the advanced nurse practitioner was particularly strong. So Ger, we'd like to hear what you believe that the role is and how you've been managing the outpatients or planning for the opening of outpatients and getting people through the services again. So Ger, I'll hand over to you, and Paula look after the slides there for you. So great.
Great, thanks a million, and thanks for inviting me to speak. I'd be short and sweet, but if you have any questions, don't hesitate to ask me. So I was just going to go through a little bit of the role of the advanced practitioner when outpatient reopens, and just to give you a little insight into my experience as an advanced nurse practitioner, primarily working in an outpatient setting. So while it's not surgical, I work in radiation oncology. I do a lot of my work within an outpatient setting. So next slide. So advanced practice is not new in Ireland. It's many years now. There's 240 registered advanced nurse practitioners in Ireland currently, and they're in over 30 specialities. I'm sure most of you are very familiar about the role of the advanced practice, be it that we all do very varied jobs, but it was developed really because there was a cohort that felt that would prefer to stay in patient-centered care rather than moving into certain managerial roles. But with that, you remain within your professional values, code of conduct. You have to have expert clinical decision-making skills, good communication and personal skills, and are very much involved in the management team and leadership as well. Next slide. But I suppose just as a reassurance to everybody, you can't just decide one morning when you wake up that you're going to become an advanced nurse practitioner. It's actually quite a thorough road to go down. You have to go to master's level. You need excellent clinical supervision, and I've been very lucky here with excellent clinical supervision and continue to have a mentor. And it's very important that there's communication between the mentor and myself on very regular occurrences if there's anything. You're also very well governed within both a nursing and medical setting. So the director of nursing is primarily my boss, for want of a better word, but I'm also very much within my medical consultant colleagues, and we very much work together in a partnership. Before you do any role, you have to have memorandums of understanding, standard operating procedures, and you very much work in collaboration. And before it starts, you have to have agreed stakeholders as to what you're going to do. I think that's important to kind of just point out, because some people think that, oh, the advanced nurse practitioner is going to go off on her own little jaunt, but it's very much a controlled job. From the person themselves, they have to be very committed, because it's up to you as an individual to make sure that you're up to date knowledge at all times, and the advice you're giving is correct, and that you are accountable. And the other benefit, obviously, of having an advanced nurse practitioner is we're obliged to do research along the way, so we're good at helping out one another. Next slide. So my current role at the moment, I'm in my role for 5 years, and when we started this role, we looked at which is quite topical now at the minute, but we looked at what we were missing in radiation oncology and what I could offer to the role. So I specialize kind of in prostate cancer and radiation oncology, and I do acute toxicities of radiation oncology as well, which is more of an on-treatment review, and I also run an erectile dysfunction clinic. But for example, in 2019, I worked in the prostate clinic. Now, I've advanced a little bit from when I started, that I do work up news and stuff as well. And so I would have seen over 1,000 patients last year, and some would be in collaboration and some would be autonomously. And I've been doing telephone follow-ups, virtual clinics for the last 5 years. And I see an average of 800 patients a year on telephone clinic. And this obviously is very beneficial because they don't come back to outpatients, they just have their virtual clinic. The erectile dysfunction clinic is based on new referrals, and I see about 200 of those a year. And then I'm involved in education and leadership and research and that kind of thing. So it just gives you a varied idea of kind of the roles that we are involved in. Next slide. The benefits, obviously, it's a very much a clinical role, and generally the people that are interested in becoming advanced practice are very much interested in clinical practice. And obviously that's one area. Follow-up area can be quite structured, so it's an area that advanced practice nurse is ideally suited to. For the patient, there's continuity of patient care. We don't move, we stay in the position. Usually by the time you get to advanced practice, you're kind of very dedicated to that particular cause. You do have a specific cohort of patients and you manage them in collaboration with your medical colleagues. And there's very much a structured clinical governance. Next slide. Obviously, we've all changed, and since March 2020, we've also had to change our outpatients, and 99% of patients have now changed to virtual clinic. The new patients, I'm involved with triaging them prior to coming to the clinic, and we also do a very much case review prior to the clinic, so we decide whether they need to come into the clinic or whether that we can actually do their consult over the phone. I suppose prior to coming to radiotherapy, everybody's aware they've had a cancer diagnosis, so that makes it somewhat a little bit easier for us. All follow-ups have changed to virtual clinic. If they're coming to clinics similar to other places, the ideal would be they come on their own, but obviously this is kind of a sensitive, no more than any other topic, they are getting information about a cancer-related illness. So we advise one relative only if we can. We bring them at different times. We screens. It's a work in progress, put it this way. Next slide. The benefits of why we started virtual clinic in the first place was to reduce unnecessary hospital visits. We were having a huge amount of, there could be 3 to 4 hours wait in an outpatient clinic for somebody to come in and pretty much told that they were fine and isn't it great news, and away you go home. It reduces travel time and expense for the patient. Because up to now our virtual clinics was primarily me, there was very much great continuity of care, and the patient was delighted that the same person was ringing them every week or every year or every 6 months, and I knew about them. Or if we were monitoring something and it was every 3 months, it was the same person that was ringing. Now that obviously is not going to be a long-term solution. It relieves pressures in outpatients. Patients are often, and when I started this I thought I wouldn't get a lot out of them, but patients are often a lot more relaxed at home. And certainly I find with the topic of erectile dysfunction, I get significantly more information. All of my consults for erectile dysfunction, the first consult is over the phone, and they're much more comfortable with me over the phone initially, and then they come in to see me. And we allow families to participate if they would like to. Next slide. I suppose the thoughts, I was trying to think of where you would, developing this service further for other advanced nurse practitioners. The key of a virtual clinic, in my opinion, is to have your aim of the clinic and what you aim to get out of it. So mine is very structured. We're looking for disease recurrence, toxicities, use a little bit for health promotion, and I use assessment tools because at least it keeps the conversation quite structured. Because I'm only interested really in their prostate cancer. I'm not interested in the bigger picture to some levels. So we keep it very structured so we don't miss anything, because if you go too off topic, what I'm actually looking for, I've missed by the time I finish the phone conversation. We were trying to, before all COVID happened, actually, we were trying to figure out how we would convert more to virtual clinic. So we started doing a treatment summary. So we started giving every patient that finishes their radiotherapy treatment, I meet with them and I give them a treatment summary. So it's a pack. So in that pack, it tells them what's going to happen to them for the next 5 years, when they have to have their bloods done, what happens if their blood is up and down, toxicities, stuff they can manage at home, that kind of thing. And that seems to be working very well, but time will tell. For an advanced practice nurse to do it, you need very good collaboration and communication with your relevant consultants. I obviously don't work just for one consultant. I work for prostate cancer patients, so I have meetings as required. If there's issues that I've had in the telephone clinic, I usually will have a certain day to meet the relevant consultant and tell the patient I'll ring them back at a certain time of another day. Everything that's done is done through policy, procedures and guidelines, and they're updated, I should say, on a regular occurrence, but as needs be. I'm also a nurse prescriber, as is most advanced nurse practitioners, so I'm happy to prescribe within my own cohort of patients. And it's very important, if you have an advanced nurse practitioner doing clinics, that we have agreement that I can refer to other people. So because there's no point in me doing a full clinic and then not being able to refer on. If somebody, for example, has a gastroenterology problem, I can refer. So we have standard operating procedures that I can refer on to other people. And if there's something outside of my scope of practice, they come back. And I suppose one of the things I find most difficult after 5 years is discharging patients. So hopefully we're hoping by giving a treatment summary that will start introducing the concept of discharge earlier, and patients' expectations will change a little. Next slide. To do it though, you do need certain things. And I'm sure all of you that have started doing virtual clinics are very much aware of this. You need clerical support. So our clerical support books and scheduled appointments, dictates the letter and makes the follow-up appointment for the next clinic. You need a clinic room. And I think that's one of the important things about virtual clinic. It has to be treated as if it was a normal clinic. So it's protected time. So there's nobody knocking on the door to say, can you just sign this? Or do you mind just coming out to see somebody? You're here, there's no one else here. That it's very much protected time, because the appointments that we do are very scheduled. So they're kind of 20 minutes per patient and you keep moving on. Now, I know you were talking about this a little bit earlier on about patient notes. In Galway, it has probably moved a little quicker than what it would have moved if there was no COVID. So there's some positives to everything. But all of our hospital notes now are on a computer-based system. So we have evolved. So the patient's chart is on a computer-based system. So you have full access to the patient's notes on the computer when you're working. My biggest advice to everyone that's doing virtual clinics is to have a set of earphones, because trying to type and listen with the phone at the same time. And we've very good links with GPs. And this, for me personally, it improved over time. I suppose people became more familiar with my name because there's letters coming in with me. I do a lot of email correspondence now with GPs in relation to blood test results and that kind of thing, and it's been most helpful. Next slide. So our patient pathway for our clinics is the patient agrees to the telephone clinic. And it's interesting, some of the patients in the last while, they weren't on telephone and said, oh no, I prefer to come back to the clinic. Now when we're seeing them, because it's transpired that they have to do virtual clinic, they're delighted with it and say, oh, this is much handier for me. The letter is sent, the date, the time is sent to the patient. So they're told that I will ring them, or the advanced nurse practitioner will ring them at 2 o'clock on a Tuesday. Please be beside your phone, be in a quiet space, have a list of your medications, and allow for no interruptions. And they're told to kind of allow for a half an hour either side, just in case I've been delayed in a morning clinic. I make the call, I do the full review, and then I dictate the letter to the GP and the relevant personnel. And then to try and address what happens if they don't answer the phone, because you could be following people around forever. So we have it in our policy and guidelines. If they don't answer by 3 in a kind of a 2-hour period, it's rescheduled. So it's moved for 2 to 3 weeks time. And if there's 2 DNAs, they're booked back to outpatients. That's where we were traditionally. And the next appointment then is arranged as per what I've dictated, and the clerical officer makes the next appointment. Next slide. Sorry. One of the things that we had found in the beginning, and I think COVID may change this a little bit because patients' expectations will change. So before, they all wanted to come to hospital, and I'm sure you're all very much aware of the waiting list. So people found that when they had treatment, then they didn't want to leave the hospital setting because they were afraid if something happened, they'd never get back in. So that they'd have to go back to the beginning again as to when they would get back in. So they're very much reassured that going to virtual clinic is the exact same thing as coming into an outpatient, and that they won't get lost. And they can be booked back to clinic if requested. There's some that just can't manage it. There's a certain population, and you just can't establish what's wrong with them by the time you get through, by the time they finish the phone conversation. So there's some that certainly can't manage it. Now in COVID, I've had some people that's English wasn't great, but they would be better at kind of written English, and they've used email. So I've done some consults over email actually in the last while, and obviously they email to me on my work email, so it's somewhat protected. For the patient and for, I suppose, the discipline, everybody, the advanced nurse practitioner that's doing the job needs to be knowledgeable and competent, and you need to gain the patient trust, because historically in Ireland, oh God, it's the nurse that's ringing me, but she doesn't really know that. So they need to, you do need to develop your skills. And I think we're talking about communication skills, but you kind of need to develop your skills that you are knowledgeable, you are competent, and if you don't know something, that you go back and ask and come back to them. All our patients have, and all the prostate patients would have my contact details. And in the beginning, I thought, I was warned, oh God, they'll ring you 100 times, but actually people don't. I don't get any greater numbers of telephone calls. I think they're reassured that they have a system in place if they need something. And since COVID, we very much updated our written information as well. So particularly if we were doing a new consult, once you're finished the consult, they're sent everything in written format with details to contact back as well to try and cover some of that. Next slide. Future new patients to OBD. This is very much a work in progress, and we have been continuing seeing some new patients, obviously, and we're continuing giving treatments. We started that we work up the clinics, and then we do a case review on the new patients and establish as to who needs to come in and who doesn't. Follow-ups primarily are through telephone unless there was some significant issue that couldn't be done. Even if patients have to come in, we're considering doing their baseline assessments over the phone first, maybe questionnaires about their toxicities, have all of the questions that you would have to ask them when they come into a clinic done a little bit beforehand, so just so that you wouldn't be too long in the room with them. But again, this is all kind of work in progress. As I say, Galway is very lucky that we do have computer-based system. So the hospital notes are all available to us on computers, so you can work with 2 screens, which is always very helpful if anyone is doing outpatient clinics. So you work with 2 screens. So there's lots of things like that that seem to work a little bit better. Next slide. And I thought this was kind of poignant. The past is important. Florence Nightingale was 200 years yesterday, and probably the first woman as a nurse that told us to wash our hands, and that still remains very relevant in today's society. And the future, I believe that nurses have a strong role in follow-up and are in an ideal location to do it over the telephone or in outpatient clinics, however it's deemed necessary. But obviously everything is in collaboration with others. And that's it.
Great, Ger, thanks a million. It's a really good insight into understanding the role of the ANPs can play in our as we reconfigure things. We're going to move swiftly on now to Mr. Tony Moloney, who's going to give us a perspective on telemedicine and how that's been going. So Tony, I'll hand over to you and look forward to hearing what you have to say.
All right, thanks a million. I hope you can hear me clearly. And Ken, thanks for asking me to give a talk. And I'd like to start off really by echoing Ger's last comment around the role of a nurse practitioner. And I think given the fairly dramatic reduction in consultant numbers over the last decade in Ireland, I think the role of the NP is going to be more than crucial as we move forward to try and roll back out our clinics. So we might bring up the first slide there, Erica, please. You hear me okay, Erica?
Yes, can you not see it?
No.
There we go.
Okay, and we go on to the next slide, please. So the college really has been instrumental in the last number of years in publishing some wonderful guidelines, all of which have been focused on patient care and the provision of surgery, both in trauma, acute care and elective care. The bottom left, I think, is now become a bit of an aspirational document, and I can talk on that at the end if you'd like. Next slide, please. I think we'll all agree, and the reason that we're all sitting here tonight is that COVID has changed all of this. It has changed the fundamental of the communication with the patient, and certainly I've felt a fog in my brain in the last number of weeks and months as I've attempted to do clinics without a handshake with the face mask. And I think we've taken away 2 of the core fundamental pieces of communication from a process which has been ingrained in all of us over many years. Next slide, please. Colm highlighted the waiting list eloquently at the very start, and it continues to grow. I suspect these are the figures from the end of March on the NTPF website, and I suspect the figures for the end of this month will focus not only ourselves but the HSE and the Department of Health. Next slide. This coupled with the projected population forecast and also the age profile of patients really presents a particular challenge. And in fact, our group was about to publish an international collaboration on communication in the elderly and the challenges in this particular age group. And this obviously ties in nicely to the whole telemedicine and teleradiology side of things. Next slide, please. Galway are lucky, we're not, and suffice to say that there is no national EMR, and I think there's a reason that Richard Cobridge hightailed it back to the UK as this was impossible. But I think that this is crucial, and in fact, and I'll touch on an eHealth Masters that I did in the past, this is an inherent part of electronic communication, and without it there's an inherent risk, and Ken, remember I talked about this at the Minute last year. I think as part of this and as part of this process is the crucial side of audit and data capture, which the college really have been instrumental in direction and rolling out over the last number of years. Next slide, please. For those of you who don't really know me all that well, I spent many years overseas in Toronto working at the General and St. Michael's. And really during that time, I was lucky. I was lucky to have done an eHealth Masters in McMaster, and at the same time was a practicing vascular and endovascular surgeon. We had weekly telemedicine clinics on a Tuesday afternoon, and this really allowed me to communicate with patients, some of whom were in excess of 2,000 kilometers away. And while surgery has only 5% of the pie of telemedicine users, this is still 90,000 encounters. And this is touched on in this very nice discussion paper on virtual care in Canada, published relatively recently. What's important about this is that it's communication between the physician, specialist, GP, nurse practitioner to a telemedicine hub, and therefore it's very secure. Present in the telemedicine hub also is an OTN, a supervisor or organizer, and obviously this takes away a lot of the issues of confidentiality, recording of the consult, etc. Next slide, please. This is a picture of my old office, and Ger touched on this. In fact, I had 3 screens for the peripheral arterial disease patients. Obviously, to the left of the photograph is the patient, and sometimes this patient could be in Emours or Thunder Bay, which are 1,800 kilometers away. To the right is the patient's CT, and obviously vascular and vascular patients lend themselves to this because obviously a lot of the investigations such as ankle pressures and a CT scan coupled with the patient's history sometimes excludes the necessity for a physical exam, and I'm going to touch on this in a moment. On the right is a telemedicine type hub that we had designed for peripheral arterial disease, and this allowed patients to in fact log in themselves and record their blood pressure, their walking distance, their smoking, etc. And so this allowed a real remote management of these type of patients and other patients. Next slide, please. The government and the department have published the operational governance guideline for telemedicine implementation, and the final document was published at the end of last month. Within this, they've discussed 3 modalities for utilization of telemedicine, including Attend Anywhere, Microsoft Teams, and WhatsApp. I'm going to talk a little bit about these individually in a moment. Next slide, please. So within UHL, myself and the team have made a number of attempts locally to roll out telemedicine. It's interesting the challenges that you face. For example, Microsoft Teams, there's an issue around domains, and hence why it hasn't really been rolled out. Skype for Business really only works internally within the HSE and poses a lot of challenges for remote access. In terms of Attend Anywhere, there's been significant delays in rolling this out, and in fact is only going live now. Within each institution, obviously, there are a number of hardware issues, and Ger touched on this, as did Colm, in terms of cameras and headsets, and also network speed. And I certainly think if you have a large number of people online and you don't have a broad bandwidth, the network can really pose a challenge. Next slide, please. So this is a bit aspirational, but I hope it will entice a number of questions. So how far remote can we actually go? And in fact, this is taken from a talk that I gave all the way back in 2014 in McMaster as part of my master's at that stage. So next slide, please. And my question is it really a reality? And I actually think it is. But how we couple this remote assessment of patients with this, and in particular with surgery, and then how we roll it out in a COVID era and in what is now being deemed the new norm. Next slide, please. So a referral is received either acutely, subacutely, or for a chronic process. Next slide. In this case, it's a gentleman with some abdominal pain. Next slide, please. And next slide again, please. So all his investigations are available on a national EMR through a unique identifier. So we don't have to repeat the chest X-ray or the bloods or the CT, and these all have become available. And they should be available nationally in Ireland. And this is something now that we have to demand, not ask for. Next slide, please. Next slide. And so, next slide, a telemedicine consultation is set up with the specialist, the GP, the nurse practitioner, quaternary referral centre, regional centre, whatever. Next slide, please. And this is a two-way thing, and it's important to remember that. And within the OTN, or the Ontario Telemedicine Network, this was between the physician, the nurse practitioner, and the patient via the hubs. So there was an OTN officer at the patient's side. And this took away a lot of the concerns around recording of the consultation, the GDPR concerns, the confidentiality concerns, the security concerns that a lot of people have voiced to me. Next slide, please. And all of these assessments can be done remotely. Next slide, please. With an ability potentially for patients then to log in and do this anywhere, potentially in community centres within Ireland. And I think that's certainly something that should be strongly considered. Next slide, please. The issue is the exam. And this is always going to be the issue for physicians, and in particular for physicians like cardiologists, respirologists, surgeons, all of whom the College of Surgeons and others have taught us that physical examination is an integral part of the assessment of patients. Next slide, please. But I think we can get around this with imaging modalities, and I think with the ability to ultrasound now freely available, the ability for CT to be rolled out in many different centres, the NIMS programme, which the vast majority of centres within Ireland are now on, all allow for integrated care. Next slide, please. And again, please, Eric or Ger, thanks. And again, a further potential remote consultation. Next slide. With the ultimate aim, of course, from a surgical perspective, is a potential surgical intervention. And again, with the aim, with the use of robotics and various other technologies, this has the potential to be performed aspirationally remotely. Next slide, please. And here you can see just an advanced EVAR on a patient, in fact, that I had seen in Sault Ste. Marie, which is a good distance away from Toronto. And in fact, I only met the gentleman on one occasion, and that was for his surgical intervention. Next few slides, you can click through, please. And again, yep, keep going. And one more, thanks. Next slide, please. So what are the challenges and what are the potential solutions? And I've really just made this quite broad. There's obviously the issues that I've alluded to in terms of the IT networks, and I think this can be circumvented by a cloud-based approach, and certainly that is what the OTN was based on. In terms of the patient ID concerns, I must say personally I have a lot of issues around the use of WhatsApp, around the use of Zoom, and around the use of various other modalities, because the user at the patient end has control and has control over recording of this, and certainly that can pose its own problems, such as confidentiality, and obviously there's an integral part of consent and the hub approach to this as per the OTN network. I think there does need to be a change in legislation from a medical legal perspective, and the crux of the issue really is the new patients and how we assess these. I had been seeing new patients in Toronto. I have not seen any via a telephone consultation over the last number of months, and it's how we adapt to allow us to see these patients. Ultimately, there's a piece on governance, and while that lies with the physician or the practitioner, I think there's a responsibility for the referring physician and also the patient. And this is something that I think needs clarity and something that I think needs to be thrashed out. Next slide, please. So virtually perfect, I think potentially, but I certainly think there's a lot more work to be done if this is to be rolled out in the Irish setting. Thanks very much.
Thank you, Tony. That was great, and we've heard this coming through now. The whole challenge we're going to have around communication is going to be a big issue, isn't it? And we might have a chat about it later when we get down to the Q&A. But Peter Gillen is going to give us an insight into some of the necessary communication skills for telemedicine. So you've heard some of the technical challenges of running it and the technical potential that's there as well. So I'd wonder, Peter, you give us an insight into what are the challenges in the communications, but also what's the upside of the communications? What's gone well on this, and maybe how do we keep moving that along? So, Peter, over to you.
Okay, can everybody hear me there?
Yes, Peter, loud and clear.
Lovely. Well, I'm conscious that Tony Cox is following me, and I want to be as brief as I possibly can. I've enjoyed those talks, and I'm going to cheer everybody up by saying I've got no slides. So I just got a few bullet points that I want to talk about, and I think a lot of them have already been raised here this evening. I think that one of the things that Tony just said there was that an EMR, a national EMR, proved impossible. I think that's interesting in that in this current COVID climate, probably nothing is going to be impossible in the future, and I think we do have to think about ways to make the most abnormal things become normal. One of the things that we've done a lot in the college on recently is try to concentrate on the communication skills that people will require in order to do some of these telehealth consultations. It's the advantages really of something like telehealth has been covered by Ger already and done well. One of the things that perhaps is also very interesting that Colm said was that there are 2,500 do not attends or did not attends to clinic every month in the country. And that's a huge problem for us. And telehealth can get around that by ringing people at home. It's a lot more convenient, as we already covered, for time and for travel, both for ourselves and for the patients. And there's a variety of things that have been shown to be successfully completed on telehealth now. From a college point of view, I think it's very interesting that although you've got experts here tonight, like Tony Moloney, who's done an awful lot of work in Canada and elsewhere, and Ger, who's an expert already, many of the surgeons in this country have little or no experience with telemedicine and will find it very challenging. And there are a lot of pitfalls associated with it. And I think we have a lot of work to do as a college to try and get people on board with this and give people some confidence. One of the things that adults achieve at adult learning stages is that they have to be convinced that a new technique is going to benefit them. They have to be in a place where they feel ready to learn, and they have to be supported in order to do that. And I think we've got a lot of work to do with people to try and convince them that telemedicine is going to get them out of a lot of problems that they're currently facing with waiting lists. And the idea of large numbers of people crowding into a hospital for a traditional outpatient clinic. So the first thing we've got to do is get the message out there that it is going to benefit people and that it can be done. The next thing is that we need to get a whole training program in place for how to do it, because an awful lot of people are now going to say, okay, I'll do that, I'll try a video consultation, but there are huge pitfalls associated with video consultations that people who don't have the experience won't be aware of. And the first thing that I would say is that given a choice between telephone and video, if the objective, as Ger said, it can be achieved by telephone, then go for telephone. It's a lot quicker, it's a lot easier on you, there's a lot less concentration involved, and a lot less can go wrong. Video consultations are very attractive in one sense. They have a lot of advantages also, but there are problems with video consultations. And again, people will need to be trained in order to use them properly. One of the big issues, and Ger mentioned it already, that some elderly people will have problems with technology. As Tony said, broadband and network speed varies enormously. When you actually use that as a video consultation, you're going to run into the problem of latency. And I think that issue with latency is a big one for communication skills. We normally would work on a conversation that I would speak and you would listen, and then you would listen and I would speak, and it would be clear when that would happen. That very often doesn't occur on video consultations, particularly if latency becomes a problem. Now, most of the time, it's not much of an issue. If it's less than half a second, you can get by. But if it becomes more than half a second, people start to talk over one another, and vital pieces of information such as treatments or dosages can get mixed and lost. And then it's very difficult to get back on track and know what's been understood and what hasn't. So there's a lot of nitty-gritty about that. It also takes a lot more time at the start to set up how you're going to conduct your video consultation. So for example, not only, as Tony said, you need to check that you have the right person, the right address, the consent has to be gone over again for the consultation, who else is in the room, and so on. And then finally, a telephone number so that if there is a problem, that you'll resort to a telephone and to agree with the person about delays, pickup, and so on, lags, a loss of video or loss of picture, and what you'll agree to do. So these are skill sets that people don't readily have and don't often think about. So overlapping talk is a big issue, and communication can suffer because of that. Secondly, both on the telephone as well, pick up for clues such as non-verbal things which we would normally do. I was interested to hear Tony say about how difficult it is now with the mask. If a patient's wearing a mask, you're not going to pick up on subtle signs and non-verbals that people will often use in a conversation. That means that you have to be more intuitive and rely on different communication skills. And again, these are going to have to be learned. And it's very interesting to see how these play out then over video. People say, well, the video will get around that because it's face-to-face. But because of latency and lag, sometimes those visual cues are off beam and aren't picked up. And they appear to be picked up because you're looking at somebody. So there's an awful lot of video skills that have to be learned. And these are things that will have to be taught. They're not intuitive. And although we've done a lot of open communication skills, there's a different transference skills to be used in telemedicine. And I think the college have to be complimented on this. They've actually supported us in the National Healthcare Communication Programme work. And now we've collaborated, and Donncha Ryan has done fabulous work with us in order to get an online telephone module up and running on the college website that the president alluded to earlier. And we hope next week to have a video consultation module ready to go online for anyone in the health service and the college to have a look at in order to upskill people in terms of communication. What I might like to finish off with it is if I could ask Erica just to run the 60-second video of the telephone link, and we're going to post this on our site as well. Evidence shows that using good communication skills leads to higher quality care for patients and those who care for them. The COVID-19 pandemic makes communication both more difficult and more important than ever, particularly for people who are at highest risk of becoming very ill. Communication Skills for Telephone Consultations is a free online course that helps clinicians to navigate telephone consultations with patients and prepare for potentially difficult conversations about COVID-19 treatment. The online course takes less than an hour to complete, and the activity has been approved for 3 CPD points. Please feel free to share this resource with colleagues. Thank you very much.
Peter, thanks very much. And just to remind everybody, and we'll put that up on the chat function, the links to that video and the links to the information that Peter referred to there and helping people with telemedicine skills. And also the college produced a guideline, which I think Pádraig has put up on the chat function as well, a link there on dealing with telemedicine for surgeons during COVID-19. So at last, we come to Dr. Tony Cox, who's the medical director of the ICGP. Tony and myself go back a long, long way, and it'll be interesting to hear from the real experts at communicating with patients, if you want, on how what it will mean for them and what it means actually. What we think about in terms of the referral pathways. How do we support primary care? How do we communicate effectively? Things like the multidisciplinary team approaches, the community hubs, all that sort of thing. But Tony's going to give us an idea of the issues that are going on in general practice and what that might mean as we get services back going again. So Tony, hand over to you, and good to hear from you.
Okay, can you hear me, Kieran? The sound is okay, is it? Yeah?
Sounds fine, Tony.
Okay,
yeah.
Great. Okay, well, look, thank you very much for inviting me on, and there's been some very interesting talks there. So I've enjoyed my time there watching the other speakers go before me. So Erica, you have the slides up, sir, so thank you very much. So this is what I was asked to talk about, and I'm quite happy to address this. And so just go ahead to the first slide there, Erica. So we've had 12 webinars, and like yourselves, you know, on our very first one of the speakers put up this slide or something similar, and it really has struck a chord with me and with most people, I think, really. You know, it's the one slide, well, there's been a few, but it's the one slide that I remember as being key. We all want our old jobs back. We really do. We want things to go back to normal. And unfortunately, we realize now this is not, you know, the old normal is not going to be there. There is a new normal. And you know, it's challenging, it's difficult, and you know, we really do hark for our old jobs back, and that's the way we still feel, you know. So like 12 webinars in, this is the slide I remember from the very first one. So move on there, Erica, thanks very much. So just to give you an idea of what general practice is like, I mean, we've done press releases, we've done all sorts of media bits to kind of remind people that we are there, we are open, we haven't stopped seeing patients. And I know the hospitals and the surgeons, you've done the same yourselves. You haven't gone away, you haven't gone into hiding, and yet our patients felt that, you know, they wouldn't trouble us, it was dangerous to come to see us. And we did put, I mean, I've got a big red stop sign on my front door, the one just like that, because we had to just stop all our walk-in clinics. Just our waiting room is closed. So the new normal now is, look, we're seeing patients with masks on. You know, we have masks on. We're wearing aprons sometimes. We're wearing gloves. We're washing the devil out of our hands, nearly down to bone now. We've erected perspex screens to protect our staff. We were talking to patients through closed doors initially, and we had to get the perspex screens done just to protect them and protect the patients and protect the staff and to get confidence back in. I mean, our staff were very worried, very concerned, and you know, we have had to do everything we can to protect them as well. You know, the whole process of cleaning after every consultation, waiting rooms closed, and those waiting rooms used to be horrible places. You go in there in the morning, you see the place full before you even started. So in many ways I don't miss that, and I don't really wish to go back to having those waiting rooms again, and I certainly can't see it happening for anytime soon. Some doctors are seeing patients in the car park, which is one way of doing it. Some patients are sitting down in the car park with chairs outside. Everyone's getting different ways around it. We still are, you know, we've got our confidence back. We have our PPE. We have worked out a way of doing it. We have a one-way system through. It's by appointment. You phone up. There's no walk-ins. We set a time. We give enough time to kind of get the room cleared afterwards. We've done, you know, we've really majorly revamped the surgery. Everybody's had to put a bit of time and money into it. all telephone triage. And it's a bit lonely. Everybody's in their own rooms and their own teams. You know, we've divided our groups in the practice into 2 teams, so that if one does go down, which drags down the colleagues with them, there's another team to step in. Our GP registrars are gone, pretty much gone. They've been redeployed to the famous community assessment hubs. One of the ideas behind the community assessment hubs was to take that COVID case out of general practice to allow us to get back to normal and get back to practicing normally. So just that's a flavour of what it's been like in general practice, just to give you an idea, and what's been happening in the hospital has been a variation of that, I'm sure. Next slide, please, Erica. So what do we need from our hospitals? You know, like access to diagnostics, we've always been asking for that. And unfortunately, one of the first things that happened was it was taken away from us. What access we had to radiology was taken away. You know, that same day chest x-ray is gone. No, that's understandable for safety reasons. We do understand it, but it certainly does tie our hands behind our backs. Our access to imaging, it's lost as well. We would love to have that access to same day advice, and I mean, I see down the bottom there, I put in the RCSI Surgeons Connect, and we really do appreciate and value that, and Kieran and everybody in the RCSI who put this together for us in tandem with ourselves, that's really, really appreciated, and it has been very helpful. But that local link with our local hospital, you know, like Tony's on there, so I mean, if I had a vascular problem, I'm going to ring Tony or Raymond or one of the vascular surgeons in Limerick, you know, first. But obviously, it is great to have that backup of RCSI Surgeons Connect. That really has been helpful. Communication is key, and you're going to see that word communication come up in my slides quite a bit. You know, we do need to talk to each other. We do need to understand each other, and I'm very grateful for the invitation on here tonight to talk to you. That willingness to help us, you know, that's important, and it's teamwork. So like all of those 3 things, they're all important. We do need clarity of information about what is available, what's actually happening in the hospitals, what services are there, and the next couple of slides after this, when we do move on, will show kind of examples of that, good and bad, mostly good. But some hospitals just haven't told us what outpatient services are there, what clinics are there, who's actually seeing patients, you know, what pathways are available to us at the moment. Surgical assessment unit, we're very lucky in Limerick now, although when you see the slide it says that it's closed to GP referrals, but it's just operating in a different way. And we do have access to the surgical assessment unit, and I can talk about that after a little while. I think, you know, everything has changed so much in our accessing of hospitals now. And we've always complained about everybody having to go in through the door of ED. It didn't suit anybody. It didn't suit us as GPs. Didn't suit our patients. Didn't suit you as the receiving physicians and clinicians and surgeons on the hospital side. It's not a system that we want to go back to. So surely let's use the opportunity to devise a different way for things. Everything shouldn't have to go in through that front door of ED. There has to be so many different ways. And so many innovations have come in during this crisis time in the last couple of months. We must use this crisis and get the good out of it, and actually get different ways of doing things. I mentioned RCSI Surgeons Connect and the orthopedic trauma clinic assessment. That has been very helpful to us as well. So next slide, please, if you don't mind, Erica. So doesn't show very well, but that's actually the Beaumont Hospital giving a very good example. So it's very hard to read it there. Of a very good example of what clinics are available. You can see there's a lot of virtual clinics there, you know, but it's very clear what is available, what times are available, who's seeing patients, you know. So that's the type of information, that's the type of communication that is really, really helpful to GPs, and I would encourage each hospital in the country to do the same, because that will certainly make it easier. Next slide gives an example of my own local one. There you go. That's what we just back to that one. That's the UL hospital group, and as you can see at the top, it's a very negative message: surgical assessment unit closed to GP referrals. But that's not the actual case. I mean, I've had a couple of acute surgical cases on Monday, not major ones. One was a pilonidal abscess. The other guy was a guy with a really nasty epididymoarchitis, and he was quite sick. But you know, they just have to go to the ED. They have to have a COVID assessment. Their temperature checked. They have to answer a questionnaire, and very quickly they're passed on to the surgical assessment unit and seen by the appropriate team. So even though it says they're starkly closed to GP referrals, which has I say, is a very negative message. The reality is different. And it was mentioned to me that it's 24/7. Now, I don't know. Tony might answer that later on. Down the bottom there, you can see the radiology service. All GP referral, outpatient X-ray appointments are postponed in UHL. Another negative message, not very helpful. And you can see what's available clinic-wise, not a lot really. So that's the challenge, isn't it? You know, we need to get back to work, and that is, you know, like that as is now colloquially called BAU, getting back to business as usual. But there is no such thing as business as usual anymore. The new normal is certainly different. So next slide, please. So the return to normal for planned GPs referrals to surgical services. So, like, what will be available in surgical outpatient? Virtual clinics, of course, as Tony pointed out, they are the way forward. And as everybody has pointed out, and as you saw in the Beaumont clinic list there, that's really the major way for delivering care at the moment. And we're doing it ourselves in general practice. We've gone from literally seeing every patient to maybe 70% plus of our consultations being by the phone. We're using video consultations, we're using video consultation tools. We have things called, there's a one called DoxyMe, that the HSE have engaged 2 providers. We have those as well. So there's a number of different ways of doing it, and they're all very, very helpful. So what type of cases will we be able to refer to outpatients? And these are just questions like, can ENT return to normal? Can maxillofacial return to normal? Scopes, are they possible? I don't know. I don't know what the answer, like what can colorectal surgeons do? What do we do with those patients who are bleeding per rectum? How do we refer patients for investigation of iron deficiency anemia? What will be available to us? I'm just asking questions because I don't have the answers, and I'm sure these are questions that you are asking yourselves. And I know that, and from my own experience in the practice, we're seeing less patients because of the infection prevention and control requirements. We have to set more time aside. It's slower. You've done some triage on the phone, you've done a safety assessment, you're seeing the patients, and then you have to clean the place afterwards and use your disinfectant and just change your gear and get ready for the next patient, and calling patients in from cars and so on and so forth. So, you know, a back to work planning document would be welcome. And again, I just see that word communication. Next slide, please, Erica. So acute surgical referrals, they're working well, as I said, in UL. But talking to my GP colleagues, we have nightly calls at 6 o'clock between a group of us, and that's not the case around the country. So, like, obviously phoning initially and talking to somebody. We have a bed bureau in Limerick, and or you might get talking to somebody directly in the surgical team. It would be great if we could send our referral letters via the secure email service Health Mail. Certainly nobody wants to use fax because it's just not GDPR compliant, but not always. Sometimes we're asked to fax, and it would be much preferable to use Health Mail, much safer, much more efficient. I've asked that question about trying to avoid that whole in through the front door VD way of doing business. I think that has to go and has to stay gone. The COVID assessment on arrival, the streaming that I talked about, and, you know, surgical assessment journeys, we've been very lucky to have it in UL. But I mean, I don't think the rest of the country has exactly got the same experience. Some areas have, some other areas haven't. And then the discharge needs to be planned, and it would be fantastic if we could get that electronic discharge summary. So that's what I would love to see, and the experience of that is mixed throughout the country. I'm lucky, not all my colleagues are. Next slide, please. So, like, the barriers, and one of the speakers earlier on talked about the barriers, and the one I put in yellow is the big one, patient fear. That is the big barrier. Like, patients really are nervous about coming to any healthcare setting, GP, hospital. Like, going to hospital is like going to somewhere dreadful. Even though, like, hospitals have gone to great lengths to make it safe for patients, GPs have gone to great lengths, spent lots of money putting up those perspex screens at whatever cost. You know, like, and we've made patient safety our priority, and our staff safety our priority, but patients are still afraid and will remain so. We were afraid, GPs, and some GPs are still afraid. We've, you know, like, and for us to get our confidence back and to get a system going that we could actually get back to seeing patients, that took some time. I've had patients in my room literally shaking. They just want to get out of there. You know, they want to come in. Their fear about their medical problem, their surgical problem, is greater than their fear of being there. But their fear of being there is so visible. It's just, it's terrible, really. You know, I find these times quite challenging, I must admit. Next slide, please. Just wanted to talk about this bit because, you know, like in the UL communication, and I don't know whether this is the norm for around the country, but preparation for planned surgical cases was mentioned that, you know, the plan would be that any case coming for planned surgery would be cocooning for 14 days beforehand. Even that little bit carries its own concerns because, you know, like we've been phoning patients, even self-isolation, like a patient who's got an acute respiratory problem like a fever, cough or shortness of breath, we're referring them for testing, and while we're waiting for the result, we're asking them to self-isolate. And then we phone them with the result, the negative result, and you expect that you're going to get a major relief and they're being released from prison. They haven't been in prison, they haven't been self-isolating to the way that they should be. So I just fear that that demand upon a patient to cocoon for 14 days, will that actually happen? Can you be reassured that the patient will actually adhere to what the advice that you're going to give them? And the second bit I suppose I just wanted to address was that pre-op COVID-19 testing within 48 hours of procedure. That's just not possible at that moment for us. The fastest turnaround that we have at the moment is 3 days, but it's been 3 days to 5 days to 6 days, and it's been even like in a few weeks ago, it was even 2 weeks. But it is down to 3 days at its best, but it might average 5 or 6 days. We just can't access it for our patients within the 48-hour turnaround time. So it's just not possible. There's no capacity. And just the next slide will give you another reason why we can't do it. Just if you do the next slide, yeah, we have these algorithms that the HBSC release, and I'm sure you have your algorithms. This is what this is our current one. We've had that now since last week. They've changed frequently. Often that, you know, they widen the criteria, they narrow the criteria. At the moment, the criteria is quite wide, but you still have to have a patient who's symptomatic, who's got at least one of cough, fever, or shortness of breath, or a patient, again, a symptomatic patient who's been in close contact with somebody who's a probable or proven case. So like we can only refer patients who are symptomatic for testing. We can't refer, we're not allowed access to for what's envisaged there for the pre-op preparation. So just wanted to point that out, and you know, I'm not so sure whether that was taken into consideration. Next slide, please. So, I mean, I'm coming very near the end now. Just again, we have no clarity on what access for our private patients. And I'm sure many of you on this call don't have that either. I've spoken to some of you who are my friends, and that same confusion, that same lack of clarity about the status of our private patients, you know, since the HSE took over the majority of the private hospitals. When the private patients ask, can I get this done? Can I get that done? Can I see him? Can I see her? I don't know. I really don't know, and you know, and I'm sure many of you don't know either. But I mean, as soon as that clarity is available, we would love to have it. We really would love to have it. It is important. And I think maybe, is it the final slide next? Well, no, it's a very quick one. I know there's important things, and this is, you know, like I heard Paul Reid outline, cancer surgery has to be prioritised, time-dependent surgery has to be prioritised. Of course it has, and he mentioned the National Treatment Purchase Fund and, you know, working through the waiting list, and I didn't put that up there because I don't know how that will work. And then just the last slide. You know, like that word communication is there in the center, you know, that's really important, and teamwork is really important, and clear pathways, that's the main thing. Really, those are the main thing. And the one in blue at the top, you know, like business as usual is an overrated concept. It's become very busy, and it's nothing as busy as it was when we were seeing so many patients and working through big numbers. And, you know, as we get busier and as we get back to normal, it's going to be very, very tiring and very, very challenging. Telemedicine and seeing patients over the virtually is not that easy, and so it's just a few ideas, just a few tips at the end. So thank you very much for having me, and there were my thoughts.
This picture of Beethoven.
So Tony, thanks very much for that.
Fellow.
And I remind everybody to use their microphones
representations from his time that actually show different faces.
And we point out, I'm going to mute everybody, and then I'll bring everybody back in, okay? That's it. Okay, so again, thanks very much for those great talks. We're probably going over a little longer than usual, but we've an awful lot of stuff to cover tonight, and there's some very, very important areas we want to look at. One of the common themes, though, that I've been trying to figure out, and you hear it a lot in the news, is that where are all our patients gone? We hear this. Where are they? We worry about them. What is it, do you think, we need to do, guys, to get patients to deal with their current fears of attending either the GP surgery or the hospital and start managing their other health needs and have confidence that the services are able to minimize the risk of COVID as much as possible, but also deal with their health demands. And I might just ask, say, Colm actually, who could kick this off. What do you think, Colm, we need to try and explain to patients about that?
I think the focus has got to be on safety and communication, as Tony finished up on. The safety, I think, is an assurance that there are practices in place that will keep them safe, that there is, as best as we understand, interventions in place to prevent and reduce infection transmission risk. But I think all of this is going to come down to risk mitigation. I don't think you're going to be able to assure somebody that there isn't going to be a consequence, but it's to balance it. So I think it's communication and an assurance that we're working to make it as safe as we possibly can.
That's good. Tony, do you want to comment? Tony Cox, do you want to comment on that? Because you know, is there a role for a public information campaign to go out and actually start reassuring people? It's, you know, it seems you need to unmute there, Tony. Tony, we can't hear you. If you just click the screen, you'll see a little microphone emblem, and you just unclick that. Yeah. So apologies, we can't hear you, Tony. You need, if you can unmute your microphone, it'd be great. I might actually just ask the same question, maybe. Ger, you're seeing a lot of cancer patients, and I would imagine they're very worried about their cancer, or very worried about the diagnosis, very worried about then, you know, they're immunocompromised or whatever. What approaches have you guys been taking to reassure patients to access service?
Well, we have been running radiotherapy services at an 80% capacity, and most likely will continue that. So that allows for scope. Now, obviously, similar to everyone else, our referrals have gone down because of diagnostics, and surgery numbers have gone down. So everybody still remains on virtual clinics, so they're contacted as would be. And if people are waiting, their kind of a virtual clinic is booked, I generally would contact them on a 6-weekly basis, but we've already gone through a plan of their risks of cancer. So we've had very little of people refusing to come in. I mean, people just, obviously they have cancer, they want treatment, and they'll come. Okay. There's some that we will be kind of deferring to start a little bit later, which we've been due to COVID. And actually those numbers have started to ring now, wondering when they're starting, since Paul Reid had come out and said, if you have cancer, you need to go and get it sorted. So the numbers of people ringing now is greater, looking to come in. But it's different if you have a diagnosis of cancer. It does give you a different light. Yeah. There's very few that would. Now, we do advise them that their GP is open also, and that kind of thing. And I agree. I think some people are a little bit more fearful in some levels of, they think if they're coming into their cancer centre that we're somewhat immune, and you do have to tell them that, you know, there's risks, but we try and take precautions. Whereas some patients would think that, because historically, I suppose, GP's practice, they would believe there's more people going in and out. So they believe that it's public perception. They believe they may be more at risk when they go in there. And I don't know why that is, but we would have no issues with anybody coming to us.
That's good to know. Good to know. I'll just move on to something else there. And there's been a few comments come in before the webinar and a few since about the issue of involving, so if you're doing, there's a lot of issues around using technology, and a lot of older patients may struggle using technology, and therefore they'll want to have maybe a family member or somebody involved in the consultation. And there might be worries around privacy and how to best consent and so on. What maybe experience, Tony, you've been doing a lot of this, obviously we're in Canada, and you're doing it recently in Ireland. Are you seeing any challenges with that, or do you need is there any clarifications needed?
Well, I mean, I think that's where the two different types of telemedicine come in. Obviously, the Ontario Telemedicine Network is from a telemedicine hub to hub. So the issues around the IT challenges are circumvented. And so you as a patient, for example, in Northern Ontario, present to your local telemedicine office. and then you would be linked into whoever the subspecialist is, our GP is, and so that gets around the user queries around WhatsApp or Zoom, etc. I mean, that needs to be kept quite separate to the standard telemedicine that we all think about, which of course is that you communicate via WhatsApp. Now, I think that's all changed, and I think a lot of the more elderly generation have been forced to embrace FaceTime, WhatsApp, and Zoom, particularly over the last 2 months, because they wouldn't have seen their grandchildren, and that has changed the dynamic dramatically. And I wish I had questioned patients pre-COVID and now question them post-COVID, and I suspect there's been a paradigm shift in that. But it's how we combine that with the ability to be secure and confidential and maintain some form of GDPR, and we'll be off the umbrella of the COVID crisis, but still the necessity to use these forms of communication and how we maintain that safety, confidentiality for the individual patient, and that's going to be key.
Great, thanks, Tony. Maybe a question, and again, I don't mind who takes this up, but it's a really good question. That obviously, you know, our GPs and our consultants are delivering having the consultations, but what about our trainees? How does we facilitate training in the kind of telemedicine side of things? Colm, maybe in St. James's, how are you guys dealing with that?
So I would welcome Peter's module, to be honest. Most of our trainees have been redeployed, Karen. They're no longer working in chronic disease care provision or consults or AMS or anything that we would have done with regards HIV medicine or other hepatitis outpatient clinics. And they are running the COVID wards in-house. So their last 8 months have almost been on a freeze. We've redeployed all our researchers out to the acute medicine wards to cover the COVID inpatient services. So there has been very little training. Now, you could argue that there's been experiential training in the context of what's happened over the last 8 weeks. We're quite fragmented. We're offering 24/7 services. So our team has, similar to what Tony was describing of going A and B, we've gone into 4 firms within a single department. So it's just a totally different way. We hardly see each other as much as we used to, and we're Zoom conferencing each other. So I think the training and education piece, we have medical students that obviously we're trying to look after. Third meds or final meds just finished on the day of our first case in St. James's because we brought the exams a bit forward. So I think the training issue really needs some thought, and a little bit like the clinical service provision, it'll require a blended approach. And that's the idea of Peter's module.
Yeah, Tony Moloney, in terms of, say, our surgical SPRs getting involved in telemedicine, running their clinics, like obviously the normal clinics that are run by themselves, how does it work with the telemedicine, or is what's needed there?
Yeah, I mean, I think a bit of innovation is needed, and I think a bit of local support is needed, but I think it's possible. I've been lucky in that, despite the fact we don't have an EMR locally, I have a relatively digital practice, and so I've actually had the ability to run my clinics from home. I've set up an office that way, and actually not prepared for this, but given my experience overseas, I had thought about telemedicine, telecommunication, and remote access. And I think we have to embrace that, and I think, you know, the government have to embrace that. I think the funding for that has to just come on, and I think we need to roll out a unique identifier, an electronic record, and embrace the telemedicine era, which is now going to become, I hate this term, the new norm.
Is Tony Cox, have we managed to sort out the microphone? No. Okay, and I suppose the other good question was about the hospitals listing out what actually is opening up and giving information out, both the GPs, but it would be worth giving that information out, publishing it for patients to see that hospitals are back in action and that they can actually attend and so on. Is that something we need to be thinking about across the board? Perhaps the President, Ken, what do you think of that as something to push out as a kind of a call for everyone to get their lists out?
Thanks, Kieran, for that. Well, we are actually working with the Acute Hospitals Division, Vita Hamilton, with the clinical programs to try and develop care pathways that address some of the issues that were discussed tonight in terms of patient safety, using new technology. The testing issue is important, and also patient responsibility. NEFID have released statements indicating that hospitals can get back to some form of normality if the capacity is there. So we would support that. But some of the issues tonight are going to be that were brought up are going to be key to this. You know, Tony Cox talking about the inability to get patients tested. We won't get back to any considerable degree of activity unless we can test patients, because we know we have to test anyone that's going to come in for certainly aerosol generating procedures to not only protect themselves but also the staff. Tony also brought up the issue of patient responsibility. I would equally share his concern that patients that have been told to cocoon themselves won't. And I think for a lot of minor procedures that will be the case. But I think we can probably be reasonably assured that if you're going for a major operation with a considerable risk of mortality, patients may cocoon themselves under those circumstances. So I think you know, we will have to address those issues, and we will have to embrace the new technology. I think webinars like this are really important for sharing the information each of us have. So yes, we will get back to normal. It's going to take, or the new normal, as Tony says, well, it's going to take some time. We're going to have to build capacity in the coming months, and that won't be easy. But I think we're all in this together, and we will do it.
Thanks very much, Ken. That's great. I think we've come near a wrap up now at this stage, but we tried to get Tony back. Issues with the microphone there. Tony, have we got you back yet? I just can't see. So unfortunately, it looks like we can't get Tony to say a few words. Well, look, I think we've been having it, we've been gone on probably a bit over than we normally would. I think that was really informative. Just to advise everybody that we will be putting all the slides and a recording of this session up on the website for everybody. It just leaves me to say thank you to all of our speakers tonight. Thanks for your time, thanks for your input, thanks for your insight into all of these areas. We may come back to you again because I think this is going to be an ongoing issue, but I think you've given a lot of people a lot of food for thought. Especially want to thank Tony Cox, who unfortunately we can't get there to come on for the last few minutes, but I think understanding the challenges in general practice, and indeed for the HSE to look at the community services and what's needed there are going to be vital parts of that component in getting things working again. So just to say again, thank you everybody. Thanks for tuning in tonight, and thanks again to the backroom team for facilitating all of the work tonight. So on that, I'll just wish everyone a very good night, and we'll talk to each other again next week. So thanks again. Bye.
Thanks.
Thank you.
Thanks, Kieran. Thanks very much.